so much, Anna-Marie, Victoria. Don't run off so quickly. I think that's set us up really well, hasn't it? Especially that last number. Thank you so much. It was amazing. Very moving as well. Okay, I know the live stream is dying to start, so I'll make a start now with the formal events. So good morning, everybody. For those of you who don't know me, my name's Dr. Rachel Hoare. I'm the Director of the Centre for Forced Migration Studies in Trinity College. And I'm also representing my Trinity College University of Sanctuary colleagues at this two-day event. I'm also a clinician and a researcher working as an expressive arts psychotherapist with unaccompanied minors in Ireland on behalf of the Child and Family Agency here in Ireland. On behalf of Trinity College Dublin and Boston College School of Social Work, I'm very excited to welcome you to our symposium, Bridging the Humanitarian, Peacebuilding and Developmental Nexus, Building Systems for Mental Health and Psychosocial Support for Populations Affected by War, Forced Displacement and Resettlement through an Implementation Science Lens. The School of Social Work's research programme on children and adversity and Trinity College Centre for Forced Migration Studies would first like to thank the sponsors of this event, the Boston College Institute for the Liberal Arts, the Boston College Centre for Social Innovation, and Trinity Global. A special thanks to Professor Gautam Yadama, Dean and Professor, Boston College School of Social Work, who's unfortunately unable to join us today, but we're delighted to see him joining online. Without the support of Gautam, in so many ways, this event would not have happened. And it's my great pleasure to be here to guide you through the next few days. A special welcome to all colleagues and friends online and in person. So we've got people obviously from Boston College, from Trinity College, from the UNHCR, from UNICEF, from the German Agency for International Cooperation, from USAID, the Global Development Incubator, the American Federation for Children, the Mental Health and Psychosocial Support Network, the Africa Refugee Women-Led Network, the Moving Minds Alliance, and organisations from around the world who work with survivors of torture, and to all students, and I know we've got a special cohort of students from Boston College here, you're very welcome, practitioners, researchers and academics who are joining us in person and online. And thank you so much for bearing with us during the uncertainties of the last few days. And thanks as well to the School of Medicine for facilitating us at very short notice. And we're all very much looking forward to very fruitful and rich discussions over the next 2 days. The symposium will highlight research and case studies that provide a view of pathways towards strengthening current mental health and psychosocial supports and social services systems and building back better in the aftermath of conflict. This two-day event will feature 2 keynote speakers and 4 interactive panels, which allow for dialogue and discussion between sessions with audience members, panelists and facilitators. Today, we're going to focus on framing the wider narrative and issues. I will explore the process gaps which we find between humanitarian responses, peace-building efforts, and development initiatives in conflict-affected and fragile settings, including those affected by forced migration. We will discuss how professionals and stakeholders can bridge some of these gaps and help to contribute to more evidence-based, high-quality and sustainable mental health and psychosocial supports and social services in these settings. Tomorrow, we'll highlight research surrounding community-based participatory approaches to strengthen and centre the voices of individuals who come from conflict-affected regions. And the final panel tomorrow will focus on implementation science and scalable interventions that can help contribute to higher quality and more sustainable mental health and psychosocial support and social services in these settings, in conflict-affected settings, to commit to the goal of building back better for individuals affected by war, forced displacement and conflict. Without further ado, I would now like to introduce you to Professor Theresa Betancourt from Boston College School of Social Work. Theresa is the inaugural Salem Professor in Global Practice at the Boston College School of Social Work and Director of the Research Programme on Children and Adversity. Theresa is currently on sabbatical at the UNICEF Innocenti Research Centre in Florence, Italy. Her primary research interest is to understand the modifiable processes that contribute to risk and resilience in the mental health and development of children and adolescents facing adversity in a variety of cultures and settings. Theresa has led initiatives to adapt and test evidence-based behavioural and parenting interventions for children and families facing adversity. And in recent years, her work has expanded to implementation science initiatives to scale out evidence-based interventions in low-resource settings, both in the US and globally, including the integration of a family home visiting intervention to promote early childhood development and prevent violence in Rwanda. She has also led the development and integration of group mental health interventions in both educational settings and entrepreneurship programs for adolescents and young adults in post-conflict Sierra Leone. In addition, Theresa is the principal investigator of a 22-year intergenerational study of war-affected youth and their children in post-conflict Sierra Leone. For many years, Theresa has been engaged in community-based participatory research, co-developing and evaluating family-based prevention programs for refugees. For refugees, by refugees, very important, delivered by well-trained and supervised home visitors with a refugee life experience, which have been evaluated among Somali Bantu, Bhutanese and Afghan resettling families in the US. Theresa has also served on the advisory board for the 2021 UNICEF State of the World's Children report titled On My Mind, Promoting, Protecting and Caring for Children's Mental Health. Theresa serves on the Lancet Commission for the Prevention of Gender-Based Violence and Maltreatment of Young People and has served as an expert to the International Criminal Court. Theresa has been profiled in the Boston College Chronicle, the Boston Globe, CNN, the New Yorker, National Geographic, the BBC, and in an interview with Larry King on the programme Politicking. And I had to cut that list down substantially. So, Theresa, you're very welcome. Thank you very much.
Thank you, Rachel, for those very kind comments. I'm just so honored to be here. This has been a dream of mine, to bring together into one room all the people I respect from the disciplines of implementation science, but also those of us working in war-affected settings and forced migration. So thanks for bearing with us through all of the changes and relocations, and I just can't thank our team enough for all of their hard work. So I am really honored on behalf of our Dean, Gautam Yadama, to welcome you on behalf of the Research Program on Children in Adversity at the Boston College School of Social Work and the Trinity College Dublin Center for Forced Migration Studies to our joint symposium. As you heard from Rachel, who's been an amazing partner, Dr. Hoare, over the years, and really bringing this together, our goal is to discuss the role of implementation science, which is sort of an untapped part of the toolkit that we can now start to be thinking about how do we use this in bridging the nexus between the humanitarian response, peace building, and the development agenda in regions affected by forced migration and armed conflict. So the topic of our gathering couldn't be more timely or more important. It is now estimated that around 468 million children are living in active war zones. That's 1 in 5 children around the world. The numbers related to displacement are also staggering. It's estimated that over 110 million people were forcibly displaced worldwide by the end of 2023. These numbers include over 62 million internally displaced people, over 6 million asylum seekers, and an estimated 36.4 million refugees worldwide, the highest ever seen. Despite accounting for only 30% of the world's population, children account for 40% of all forcibly displaced people. It's an unsettling reality, and it's a truth that at this moment in our lifetimes, we are facing the largest humanitarian disaster since World War II. So I'd like to share with you a little bit about my own personal experience that brought me and motivated my efforts in helping to plan this symposium. So I first began working in school-based mental health, working with refugee and migrant populations, eventually moving on to collaborate with some large international NGOs doing work in sub-Saharan Africa, and then decided to pursue my doctorate in psychiatric epidemiology and maternal and child health at the Harvard School of Public Health. When I first began in this field, it was 1995. and I interned at the Office of the UN High Commissioner for Human Rights. Our office was a co-sponsor of the very well-known 1995 Grassa-Michel study of the impact of armed conflict on children. Back then, when we'd look at the literature, look at the evidence, look at the reviews, when it came to mental health and social services, we would say, we really don't know what works in terms of mental health and psychosocial supports. And Dr. Toll is going to be giving the keynote, and he'll talk about the important work of the Interagency Standing Committee to help us think of these services along a pyramid, moving from community supports to more focused clinical supports. And we call them MHPSS services for short. But the truth now is that in 2024, we have a range of studies. We have systematic reviews that have been demonstrating a range of adapted standard interventions and interventions that come from the ground up, can be done safely, they can be effective, they can be provided in community settings for war-affected children, youth, and families. We've also innovated to address the human resources challenges we face. In Sierra Leone, where Yinka and I work, you have a population of over 8 million people being served right now by 2 psychiatrists. So you can't look to the highly trained professionals all the time to do the response. But we do see innovation where folks like Vikram Patel are leading the charge in research around task sharing, task shifting, that we know that we can help non-specialists who are well-trained and supervised provide with careful supervision evidence-based services to those in great need. We've also innovated in terms of integrating evidence-based MHPSS into new delivery platforms in places where systems are weak or non-existent. This includes education, primary care, social protection, nutrition and feeding programs, child protection initiatives, and programs focused on economic strengthening livelihoods and entrepreneurship. We just finished Youth Forward in Sierra Leone, where we integrated evidence-based mental health into livelihoods programs. So now that we have numerous reviews demonstrating that we have interventions that can be effective, it's really time as a field that we push our science further. We have to push beyond asking questions of does it work, randomized control trials, to start asking questions more grounded in implementation science, the science of scaling, sustaining, and improving quality and the reach of evidence-based interventions to those who need them. These include questions such as what strategies, testing strategies that work best for scaling MHPSS services and sustaining their quality. What incentive structures can result in greater reach and sustainment of evidence-based practices when social services are delivered? What supervision models can we test that are best for allowing that rapid cycle feedback to inform practices for upholding fidelity and improving competence of non-specialist workers as well as professionals? What are the policy structures that work best for institutionalizing evidence-based services and ensuring adequate financing and human resources strategies in regions affected by war or forced migration, or those hosting forced migrant populations? These are not easy questions, but the good news is there's a whole discipline of implementation science that's been asking questions exactly like this within higher resource settings and increasingly in low resource settings. But we are not applying these tools yet with the rigor that we need to address situations affected by armed conflict and forced displacement. So from much earlier on in acute humanitarian emergencies, we need to be thinking about the future. How can what we're doing in the right now translate to something more sustainable that helps to build back better in a war-affected setting? How do we build on the political will and the resourcing that comes in the acute emergency to translate that into systems that can have greater reach and deployment-focused interventions that are, from the get-go, we're thinking about how scalable and how sustainable is this? Does this fit the culture, the context? Can we do this at scale effectively, and how do we improve quality? This is all about building back better and strengthening trauma-informed systems and services. So before I introduce our keynote, I want to provide some words on behalf of our Dean, Gautam Yadama, who was unable to make it but asked me to share these words. Amid such enormous global-scale crises, it's appropriate that the Boston College School of Social Work's research program on children and adversity and the Trinity Center for Forced Migration Studies are collaborating to take stock of designing systems of mental health and psychosocial support for populations affected by war, forced displacement, or resettlement from an implementation science perspective. That is a great strength of our school. The Center for Social Innovation at the BC School of Social Work and the ILA Grants Program are pleased to support the symposium and partner with Trinity. We're also supporting the participation of the next generation of undergraduate, master's, and doctoral students from several different universities in this conversation in Dublin. As a leading school of social work in the US, we're responsible for shaping the subsequent generation of thinkers and scholars to secure a better future for those whose futures are compromised by war and conflict. I'm grateful to the Trinity program, to Professor Rachel Hoare and her colleagues for their partnership, and I think myself and Gautam and Rachel and everyone want to thank Rachel Strom, Libby Evans, and Jameson O'Sullivan for making this happen. So can we have a round of applause for this amazing team? Talk about grace under pressure. Amazing. So with that, I'm happy to introduce our keynote speaker, Dr. Wietse Tol, who is Professor of Global Mental Health at the Section of Global Health at the University of Copenhagen, and Endowed Professor of Global Mental Health and Structural Vulnerabilities at the VU University Amsterdam, Adjunct Professor at the Department of Mental Health, Johns Hopkins Bloomberg School of Public Health, and Senior Advisor with Health Right International. Dr. Tol holds an MA in Clinical and Health Psychology, a PhD in Public Mental Health, and was a postdoctoral fellow at Yale University. He focuses on multi-sectoral integrated interventions that address mental health and the social determinants of mental health. He's interested in understanding how research can lead to improved practice. We thank you, Dr. Tol, for joining us today, and we're honored to hear you speak about integrated multi-sectoral innovations. Please come on up. Thank you.
Which one goes forward and which one backwards? It should be.
They didn't tell me.
Let's see red and green, right? Yeah, let's pick this one. Good morning. Thanks very much for the invitation to speak at this event. Can you hear me okay? Yeah, thanks a lot. It's a great honor. Wonderful to see so many familiar faces and to be speaking to this topic, which is very dear to my heart, the topic of thinking about how we can bring things together in multi-sectoral integrated interventions. I think, it's been really interesting to work with Theresa over the years. I think we've noticed that we can spend a few years apart, then meet each other over coffee. I noticed that we're thinking exactly about the same things, and I'm having exactly the same feeling again today. So I'm going to talk about this slide, because this is what will stay up for me most of the time. Let's see. Yeah. Yay. Okay, so I'd like to talk about 3 topics. I have about 30 minutes, and then we have 15 minutes of Q&A. Would love to talk with you about this. I think this topic is really at the forefront of my mind and of the forefront of many people working in the field, and it requires a lot of discussion. So would love to do that with you together today. Sorry, I wanted to go back. So start out with just saying why I think it's important that we look at multi-sectoral integrated interventions. Then talk about the trajectory of one particular intervention that we've been working on with a team of people in Uganda, kind of as a case study to take you through about 8 to 10 years of research and practice and what we've learned over the years to kind of focus the conversation, and then end up with some key dilemmas and questions that occupy, I think, us in the field. And when we think about going forward, what are some of the key questions we're going to face or are facing? So first, to start with the rationale for why would we do multi-sectoral integrated interventions. Maybe I should say first what I mean with multi-sectoral integrated interventions. With that term, I mean interventions that address both psychological skill building. So, for example, psychotherapies or lower intensity psychologically oriented interventions, together with interventions that address the social determinants of mental health. So things in our environment that give us greater risk for suffering psychologically. Things like poverty. And poverty and mental health, I think poverty is the best studied social determinant of mental health. And even though the term social determinant seems to imply a kind of one-way direction, it's really a social process we should be talking about, or a psychosocial process. And so this is from a quite recent systematic review on how poverty and mental health hang together. We know from epidemiological research that poverty is a very potent risk factor for experiencing mental ill health, but how is still a very much studied question. So theoretically, and what we can gather from studies so far, is that there are a host of mechanisms potentially involved, but what is key to what I'm going to talk about is that there is not just a one-way interaction. This is not a simple story of a virus and a disease. This is a story of complicated bidirectional relationships. Poverty is a risk factor for mental health, but when you do develop mental ill health, this becomes a further risk factor for more adversity. And that's key. And it's not just for poverty and mental health that this is the case. If we look at migration and mental health in European or high-resourced settings, the story is also complicated. You may come to your destination with risk for mental health concerns. When you're in a host environment, there are a range of post-migration difficulties that make it very hard to maintain your mental health. And then social integration. For example, I'm working in Denmark these days. Social integration is really challenging, and we know that social integration is a key protective factor for mental health. So you see a similar back and forth relationship there too. The same seems to be true for intimate partner violence. Gender-based violence is a key social determinant for mental health. Intimate partner violence is the most common form of gender-based violence, also in humanitarian settings. And research seems to indicate that intimate partner violence is a very stable risk factor for mental health concerns, but vice versa. When you develop mental health concerns in abusive relationships, it makes it harder to escape abusive relationships. This is a much more contentious relationship, of course, and I want to do that contention justice. But research seems to indicate longer-term back and forth relationships between social determinants and mental health. If that is the case, we cannot just do one thing or the other, which is very much what we're doing now. It's not just a matter of doing something for the social determinant, for example, protection interventions, or doing something around the psychology in the health sector or cluster, right? We have social determinants, and they relate to mental health concerns back and forth, which relate again to social determinants, which relate again to mental health concerns, right? And so forth, in complex downward spirals, in vicious cycles. We need integrated approaches, and approaches that address both the social determinant and the mental health concern. And what I want to open up for discussion is that we may also need to think about the structural determinants of mental health, because these relationships do not operate in a vacuum. Inequities structurally related to gender, to caste, to ethnicity, to social exclusion based on sexual orientation or religious preferences play in the background a longer-term structural role and shape these processes. Right? So I'm making a distinction between structural determinants that happen in even the further background and the social determinants that have a more proximal effect on mental health. What do we do about those? All right, so I want to talk briefly about the trajectory that we've gone through with an intervention called Self-Help Plus that we implemented with South Sudanese refugees in northwestern Uganda. Self-Help Plus, for those of you who don't know, was developed initially with funding from WHO in Syria, where there were very strong barriers to providing care to people in remote areas without access to care. And the question was, what can we do to reach people in those kinds of situations? It was developed by the World Health Organization, together with people in this room. And the question was, okay, we know we want to do task sharing, we want to bring psychotherapies in simplified forms to people in community settings, but can we push this even further? Research had shown, WHO had developed guidance for stress-related conditions and came up with stress management as a recommendation. And those are often measured in control groups, very low resource interventions where you tell people about what they can do to manage stress. At the same time, systematic reviews came out that showed that guided self-help is as effective as therapist-delivered psychological interventions, right? Different than unguided self-help, but guided self-help is as effective. So of course, for an organization like the World Health Organization that caters to ministries of health that are completely overburdened by the need, as we all are, they wanted to explore the potential for guided self-help interventions. So this is a 5-session intervention that is delivered through audio recordings that you play in larger groups, 20 to 30 people in the room, and you give them a self-help book, mainly drawings, that repeat the messages from the audio recordings. People sit together in the room, listen to the audio recordings, talk together, do some exercises together amongst themselves, and then get the book with them. Based on acceptance and commitment therapy, so closer to mindfulness-based approaches where you don't try to fight the emotion, but you learn techniques to be with the emotion, and where you also think about what kind of person do I want to be? What values do I hold? All right, so a longer-term trajectory. At the top, you'll see the kind of stages that we've gone through. That must be a little hard to read, but I'll take you through it. The first phases were really translation and adaptation. So we worked with the WHO and many others, UNHCR and others, to first translate the intervention. After we had done a needs assessment, a participatory needs assessment to understand what are the needs here, it seemed that there was a really good match between the focus or the concern in northern Uganda amongst South Sudanese refugees. A focus on overthinking seemed to fit really well with what WHO had been developing. So we translated it carefully, piloted it multiple times, and what we found out was that we needed to integrate more group-focused activities in it. We found out we needed to start a separate trajectory for male refugees. It was harder to engage with them, so we decided with the limited means we had to first focus on female refugees. And overall, we found that with a well-translated and adapted, carefully adapted intervention, we had something that was relevant, that was feasible, that was safe and acceptable. We then conducted a cluster randomized trial and found that indeed Self-Help Plus was able to reduce psychological distress, symptoms of a range of mental disorders, especially anger, and improve overall subjective well-being, reduce functional impairment. Importantly, we did not find that the intervention effects were different for different groups of participants. So length of time in the refugee settlement was not impacting the effectiveness of the intervention. And importantly, baseline levels of distress were not moderating the impact of the intervention. Also, what I thought was really interesting is we found, in support of the theory of change of the intervention, that an increase in psychological flexibility, which is a key mechanism for ACT-based interventions, was indeed mediating the impacts of the intervention. So we could see that the mechanism, the intended mechanism of the intervention played out in our findings. Yeah, much more to be said about that, and happy to talk more about that, but I'm going through this in jet speed. Okay, after the cluster randomized trial, as Theresa said, you then are confronted with the question, okay, we have an evidence-based intervention, and then what? Right? So then you get into questions like the one that we still had on the table, what about the men? So we were quite interested in adapting the intervention for male refugees, and we did more participatory implementation research to understand what their needs are, how we can reach them. And it turned out that for them, the biggest component that we needed to add was an alcohol-focused component. So after a lot of adaptation and trying to understand how we can reach this population, we came up with a combined intervention that added the WHO's brief screening and intervention approach called ASSIST next to Self-Help Plus. I'm just mentioning that to show you what kind of trajectories we went on after the trial. I think for this conference, the most important component and our next step we took was to think about scaling up. And so we started the trajectory with the Humanitarian Innovation Fund, which was kind enough to fund us, but also to take us on a capacity building trajectory. So we were part of many different capacity building workshops in which we learned a lot of different language from the business innovation world and the social innovation world around business models and consumer needs and niches and strategic thinking. And we started thinking, okay, we have to come up with a 20-year plan. We were thinking about a 2-month plan. We had to think about a 20-month plan, or a 20-year plan. What do you want after 20 years? And yeah, that really helped us to develop a stronger vision around what we wanted with Self-Help Plus as an NGO called Health Right. What do? We are a small NGO. There's no way that we can, in 20 years, do the things, spread SH Plus as far and wide as we would really like. What we need to do is connect with interventions that are already working at scale and provide a kind of wraparound service. So we developed Self-Help Plus 360, which is a kind of consultancy-based wraparound model starting from the needs assessment. What do we need to know about the intervention resources in the particular humanitarian setting? What are the needs? What is the infrastructure? Who is currently operating here? Where are the gaps? Where do you slot in SH Plus? And then what? The capacity building. How do you train? Who do you train? What does the training look like? What kind of supervision and monitoring evaluation systems do you need? So that was a key part of the scaling up project. The other key part that I've been especially interested in, and this is to connect the previous part of what I've been talking about, I think Self-Help Plus is one of many interventions, and I'm not sold on it. I think it's very interesting. It has its strengths. It also, of course, has its limitations. What I think is very promising about it, and where we can find a good niche for it, is that it's very simple. And it's for the first time that I felt we could go to, for example, a livelihoods organization, and we could say, you can do mental health. Before that, we had 8 or 12 session simplified psychotherapies. And those organizations told me, sounds good, but good luck with that. That's not us. That's not our mandate. We don't know how to do that. We don't have psychologists. But with this intervention, I think it is hypothetically possible to integrate it into the work of multi-sectoral agencies. So that's what we tested in this program. We worked with BRAC, which is a large NGO focused mainly on livelihoods, and we tried out the wraparound SH Plus 360 services, and then COVID hit. So in a 2-year program, we only had maybe 4 months of operation, but in those 4 months, through a training and wraparound model, we reached more than 2,000 refugees. So I think there's hope for the scalability of this model. We learned lessons, and I'm happy to talk about them, but I think overall we could say that this model worked, with caveats. Okay. Sorry, I'm giving you tastes and bites of things, and but happy to talk more. How many minutes do I still have? I'm good. I have time. I'm surprising you with the time question. That's nice to not have that the other way around. Yeah, so this is the part of the talk I really wanted to have a bit of time for. What are the key problems going forward? Because I feel what I have presented is a kind of trajectory that many of us have gone through in one way or the other. And so I would love to set up a discussion around some of the key questions I think we're facing. The first one is a backflash to, or flashback to, that structural question. What can we do to address the deeper underlying issues that affect mental health? And this is the reason why I was interested in multi-sectoral integrated interventions in the first place, right? You find yourself in northern Uganda, and you're in a clinic, and you're seeing therapists with women, and they're providing evidence-based psychotherapies, but you know that these women will go back to a home where there is an alcohol-abusing husband who is violent, and she has 7 children, and she's worrying every day about how they're going to feed these children. In those situations, it's great that you can give an evidence-based psychotherapy, but there are all of these other factors. What can we do about that? I think that is still somewhat of an open question. The social determinants question, I think we're better at. We're starting to think about integrating mental health components into livelihoods interventions, but what do we do about gender-based violence? What do we do about ethnic exclusion? What can we do? What should we do? What's our mandate as humanitarian actors? Right? I think there's still a lot we need to think about there. And I've really felt that a structural injustice approach, for example, this one, there are quite a few of them. This one was published by Powers and Faden. Bioethicists, right? Political philosophers. I think their framework is very helpful. They start out with a kind of Aristotelian-informed approach, so a eudaimonic approach, thinking about well-being as the basis of all public health efforts, and then thinking about, okay, well, what does well-being consist of? What is well-being? And health, yes, health is a part of that. But there are many other components to well-being. How do they interact? And we've tended to think about the interactions between these square blocks, but we haven't always thought about the interactions with these overlapping background, social and economic, right? Where an economist or a justice scholar or a feminist scholar will do their work. Right? It's a different way, at least for me, it was a different way of thinking about mental health, not as this collection of symptoms or disorders that you are somehow going to address with the perfect medical or psychological solution, but rather as the internalized condition of adversity. It's adversity structurally under the skin that continues to play a role in the fair chances to a happy life that people get. It becomes not a question of medicine, but a question of justice. Right? And this theory is good in translating that question of justice into a well-being model that gives us a broader set of tools to analyze. If we wanted to or not, these background conditions are there. So it's not a matter of thinking them away, it's a matter of getting the analytic tools to allow them into our work. The other thing, the other thing I think that is critical in our work going forward is that we go deeper and that we understand these red arrows better. Right now, I think the level of our epidemiology is really at the risk and protective factor level. So we think about this in the kind of balancing scale way. We have a bag of risk factors, we have a bag of protective factors, and somehow with some kind of universal mathematical magic, you come out with risk or resilience. And yeah, that really will not cut it if we want to develop smart, integrated interventions. We need to understand what is actually going on here. So think back to the slide with the mechanisms between poverty and mental health. We're just starting to open up these black boxes, and we need to do that for all of the social determinants that we are working on. We need to get into why these relationships occur, why they occur again and again over time. How does adversity translate into physical, psychological patterns of behavior that continue to put people at risk, that continue to put population groups into unjust situations? Right? So think about the failure of the American dream. Sorry if I'm breaking promises here, probably not, but right, it's that mechanism. How is it not just a bootstrapping and lift yourself out of poverty question? How is it that centuries of adversity are solidified into people's bodies and societies? These are tough questions. They're easy to bring up. They're really difficult to engage with. They bring up contentious questions. They bring up questions around social activism and around justice, and I think they should. And we should not scare away from those questions. Because, very pragmatically, we will not solve the interaction between social determinants and mental health by just adding things together. We cannot solve this problem through some kind of monster interventions where people get and livelihoods and women's protection and child protection and mental health interventions. We need to build smart interventions that address the pain points, the nodes in the system where change is possible, where downward spirals can become upward spirals. The nodes of change in family systems, in community systems. How do these adverse systems hang together? How many things do we need to change before the balance in a system tips? Thank you. Right? So these are systems questions. They are not individual questions. They are questions about how things hang together. The third question I think we need to wrap our heads around in this field going forward is the question around how do we do this together? And with together I mean us together in this room, because we come from different disciplines. Even though I felt a sense of vindication when the psychologist word was mentioned, I know that there's many different disciplines in the room. And we don't just work together. I've been a part of several research projects now where people from different academic disciplines get involved, and we don't just work together. I remember a research project in Tanzania where we were working with a large NGO that incorporated different sectors within it, and the health sector, or the health team within that organization, finds it hard to work together with the protection team in that exact same organization. They grow up with different cultures, with different mandates, with different words, with different funding streams, with different pressures on their work, with different schedules, with competing activities going on the same day. It's really not easy to work together. That's the same within the university, that's the same within the world of policy, that's the same within NGOs, within UN agencies. It's hard to open the door and talk with the person in the room next to you. The fact that we work in a siloed humanitarian infrastructure or a siloed development infrastructure makes this really hard. but our academic expertise is also siloed. Right, so this is a kind of diagram that I like to think about, just also to stay within the limit of our time, but also to think about what these words mean. Disciplinary, right, we work in our different disciplines. If we start to be in the same room, we're working in a multidisciplinary way. If we actually start really learning from each other, we're working interdisciplinary. As soon as we start leaving the university, and we start not just to work between our academic disciplines, but we actually work with people with lived experiences within our communities, then we're working in a transdisciplinary way. And that's not always made easy by the calls for proposals that we just have to work with. The straitjackets we have to put on. But, like Theresa said, just like there are libraries of implementation science, there are libraries of transdisciplinary research. And I just had a conversation with Rebecca in the car about, for example, the boundary object, right, that comes out of sociology of science, where you find a word that sits at the boundary of the different academic disciplines. And we are using the boundary object, the word vulnerability at the moment, in a European research project on prevention and promotion, to understand how we use that word very differently. Resilience is one of those words. Rebecca mentioned trauma as a potential boundary object. We use those words differently, but we all use them, so it's at least a point of connection. There are bridging theories. My hope is that the structural injustice theory that I like working with can be a kind of umbrella theory, a bigger picture of what we are all trying to somehow achieve. That when we go into the same room, we don't say, I work on women's protection and I work on mental health. No, we all work towards well-being or reducing structural injustices that occur through all of our fields, all of our concerns. But if we don't address this, we're not going to solve this problem. This is a problem, this is a monster of our own making, and it's something that we need to bring back into the room. Those are three key questions. I think there are more, but I'm really looking forward to hear your thoughts on, what other questions are, how we can address them. Thank you.
Questions for Dr. Toll? The mic is yours.
Thank you. Thank you, Wietse, for your presentation, I think, which really hit a nerve on many levels. I have a thought/question because, as you may know, Germany is now working a bit more under a feminist development policy framework, and that gives us a bit more leverage to also look into applying feminist and decolonial and post-colonial MHPSS approaches. I'm Alena from GIZ, in case you don't know me. And what one research project we are currently having is to see in how far feminist MHPSS approaches can really inspire people to raise their voice for social change, to question the structural factors that you were mentioning. But obviously with this comes the potential risk that people are more aware of the structural factors that impact their mental health, but we are not changing the structures. So what we are seeing is that through MHPSS interventions, we can invite people to question those behavioral patterns and cognitive patterns that you were mentioning, but by that also comes really the risk of worsening mental health because of heightened awareness of those structural issues. So this is something we are currently fighting with, working on. And I was question to you and also to the rest of the room, do you have experience with feminist MHPSS approaches going into that direction? What impact do they have on people's mental health, and how could we go about this issue? Thank you.
Thank you. Yeah, great question and great initiative. I'm very happy to hear that. So a modern iteration of feminist theory is intersectionality theory. And intersectionality theory and structural injustice theory are deeply interconnected. They, I think, pinpoint the same kind of issues. So in a way, I think we're moving in a similar direction there. So I'm very happy to hear that that's an ingrained policy initiative. And I'm not sure if I agree with the risk that you sketch, because to me, that's not a risk, that is a benefit. I think increased awareness for populations about the structural factors that influence their well-being is increased opportunity to understand where they can push these systems to be more just, and for you and your partners to better understand two things. Firstly, where not to do harm. Because if you do not understand how structural factors impact mental health, you may be implementing interventions that strengthen these structural factors and thereby inadvertently do harm. Right? So, and you want to avoid that. So better understanding where the structural pain points are is necessary, I would say, not a risk. And secondly, not just to avoid harm, but also to understand how you can actually work on these structural factors. Not everybody will have to transition their work into fully focusing only on the structural factors, right? It will always be an ecology of interventions necessary. A system of interventions will be necessary. And activists and policy level interventions will be necessary to address the structural factors. That's not always up to people like me, right, who work in a university or with a humanitarian NGO. I think that's up to community members and activists in the places that we work. And we can play our role in helping, supporting activists, and we can be activists ourselves. But we don't all have to work as activists to have a positive, constructive role. It's still very much possible to do upstream work to address post-traumatic stress disorder in clinical settings. I think many activists are very grateful for those kinds of services, right? But I think the question that I'm putting forward is, how can we work better together? How can we work collaboratively to not just sit in our silos or our layers in the pyramid and do our own within layer or within discipline work, but how can we get rid of this triangle, make it a ball or a circle or whatever, or a star or whatever symbol works for you, and say, we're doing this together. Well-being is what we are all trying to, right? Justice, well-being, these are the things we are trying to achieve in the world, and we need to deeply work together to achieve them. And so from the get-go, we're going to have to develop multi-sectoral integrated interventions that address purposively, right? Not just randomly, but we've thought about where we need to direct our efforts. That is, I think, a direction that would be fantastic if we started walking on. That wasn't English, but I hope you get my drift.
Thanks, Wietse. Very, very important work. I'm Anne Willhoite with UNICEF. I am wondering your thoughts, and maybe all of our thoughts, on how we, as we're researching this and diving more into this, how we can make sure that the onus or maybe the stigma is not on the individual and rather on the collective systems and how we are changing those systems. I think that is the backdrop to everything you're saying here, and I think probably all on our intentions, but I can imagine the headline being taken from research like this or efforts like this being, poor people have bad mental health, or immigrants have bad mental health. How do we put that onus on the systems and changing that collectively and not on the individual?
Yeah, that's an absolutely critical question. I think it is easier to avoid the risk of medicalization when we collectively develop multi-sectoral integrated interventions than if we just sit in our disciplines and hope for the best. Because that's what we are currently doing. Right now, the systems are pressuring the well-being of the people we care about. And we are not coordinated enough to do something about that. That's the real problem that's the problem I'm bringing up, whether we want to or not. At least by talking about this problem out loud and addressing the elephant in the room and saying, this is why this is happening, and we really need to start, addressing this together. And it's not the fault of the person in the abusive relationship that she's in the abusive relationship, but we do need to address mental health if we want to sustainably get her out of that relationship. I think that kind of conversation is more helpful than to just sit in the clinic, treat the depression, and move on. So for me, it's just a respect for it, a getting out of a zero-sum game kind of mentality about sitting together from the beginning to develop our theories of change together, thinking in a bigger picture, and giving everybody their space for their interventions. Right? It is good to provide services to treat PTSD in women that are in abusive relationships. And it's probably also good to treat their husbands for alcohol misuse and abusive gendered patterns of coercion. But we also need to look at how income opportunities in a refugee camp may play into an abusive relationship, or how advertisement around alcohol plays into these issues, right? They are wider systems, and we can pretend they are not there, or we can try to collectively tackle them head on.
One more question.
Sure. Thank you. Yeah, thank you for a great talk. Greg Ahrens, University of California, San Diego, and Editor-in-Chief of Implementation Science. So I like the idea of thinking about the transdisciplinary issues in the work we do. And in your talk, you were talking about it in terms, sounded like mainly in the academic sphere. I think approaches like co-creation can help, and really bringing in that co-creation lens. And one of my colleagues, Monica Pereziolis, did some nice writing on that. But also being aware of issues of power and equity that arise from our funding structures and timelines that you have here. And Megan Stanton and Samira Ali did a really nice piece on power and equity in implementation research. And they used the exploration, preparation, implementation, sustainment framework as a backdrop for that, talking about how even the notion of implementation, who is implementing, who's involved, can create power hierarchies and power structures that we need to be aware of, both in the outer policy and system context, but also within organizations that provide services. And I would venture to go a little further and say, even in our work with research and collaborations. And one tool that we've been working on, we have a center funded by the National Institute for Mental Health in the US, focused on team effectiveness in implementation. And we construe the implementation teams or teamwork in implementations across levels and across participants and collaborators and co-creators. So just a comment, but wondering how you might see the approach of thinking of teams helping with this transdisciplinary issue.
Thanks a lot. Yeah, thanks for bringing up those issues. So I think at the level of the interdisciplinary is when we mainly speak about academic disciplines working together and doing something new. And then the word transdisciplinary is supposed to denote the step even further when you do co-creation approaches, right? When you define your problem in close collaborations from the get-go with the people whom it concerns. people with lived experience, but also a range of other stakeholders around practice and policy. So I think, yeah, transdisciplinary research is here to stay. I'm very grateful for ARC International to allow me to work with the Athena Research Institute at the VU University in Amsterdam, which is all about transdisciplinarity. And they work with terms like boundary objects and bridging concepts and theories to think about how can we all work together in different ways, where it's not just the researcher in the academic building coming down, doing some studies and going back again, but where this is really a joint problem-solving effort. And I think there's a large literature on that topic that we should learn from. And the way that that I'm currently working with it is in a European research project called ADVANCE that's focused on prevention and promotion of mental health of people in particularly vulnerable situations in Europe, where we should also do global mental health inspired by equity concerns. And so, for example, yeah, this is a project across different stages in the life course. So we are thinking about prevention and promotion amongst youth affected by climate change, as well as mental health in the workplace, mental health of migrants, and mental health in older adults. And actually, it's not surprising that in a consortium like that, we're going to have to do a lot of interdisciplinary work. And so what we've done is we've set up a work package specifically focused on interdisciplinarity, and we have picked a boundary object, in our case vulnerability, and every month we ask somebody from a different discipline to present on state-of-the-art approaches around the boundary concept of vulnerability. And we have a Socratic dialogue. We critically question where those state-of-the-art practices come from, what assumptions underlie those practices, what is baked into the thinking around that boundary concept for the different disciplines, so that hopefully we can get to know each other better. The goal is not to all think the same. The goal is not to all agree on what vulnerability, for example, means. We're 1 year into the program, I can see we're not going to achieve that. But what I found really interesting to see is that just as much with mental health in older adults, where colleagues are really concerned about the term vulnerability to cognitive decline, for example, because they can see there's gender, there's ethnicity, there are early life events that create risk for cognitive decline, just as much as they don't seem to really like the term vulnerability, as in you are a vulnerable person. It's the same with our colleagues working on migrant mental health in Denmark, where we have one of the most repressive migration regimes in Europe, at least. Right. So the term vulnerable refugee, when it's really the system, the legal framework, right? That there is a lot of protest against that with them. So it's been really nice to see through those dialogues what we share. So both transdisciplinarity by getting better at co-creation and thinking about problem-solving teams rather than research from an external kind of source, and better interdisciplinary interaction. I think both are going to be key if we want to solve these really complex, wicked problems.
Thank you very much, Professor Toll, for giving us lots of food for thought as we go into our first panel, excuse me, which is the problem of the relief to development gap. And how this is going to work is that we've got 2 moderators and we've got 5 panelists, and they're going to come up, and I'm going to firstly introduce the 2 moderators. So if everybody would like to come up first, maybe that's the easiest. before I introduce the two moderators. And then I'm going to hand over to the moderators. Thank you. Take a seat. You just want to take a seat? Yeah. Thank you. Okay, thank you everybody. Thank you so much for coming and being part of the first panel, the problem of the relief to development gap. So I'm first going to introduce Dr. Ganzamungu, Ganza to his friends and colleagues, Zihindula, who's just here. And Ganza is a Global Atlantic Fellow for Health Equity. He holds a PhD in Public Health from the University of KwaZulu-Natal. He's published more than 30 peer-reviewed articles and has presented at more than 50 national and international conferences. Dr. Zihindula's work is influenced by his lived experiences of forced migration, his advocacy for refugee inclusion, and their equal access to human rights services. He works as a research scientist at Trinity College to implement a translational simulation for trauma-informed care intervention to improve the quality of care for staff and patients who have experienced one or more traumatic events in their lifetime. Ganza is a member of the steering committee for the Centre for Forced Migration Studies, a co-founder of the South Africa Refugee-Led Network, and founder of the Urban Refugee and Asylum Seekers Assistance Organisations. He and other Global Atlantic Fellows, some of whom are here, are actively involved in prevention and promotion strategies of brain health and mental health for asylum seekers and refugees in Bosnia, Ireland, South Africa, the UK and Uganda. So welcome, Ganza. I'd then also like to introduce Barbara and Kozee. I think I'm going to call you Barb from now on. Yeah, is that right? So Barb is a second-year PhD student in ethics in Boston College's theology department. She received a BS from Georgetown University in international political economy with a minor in Spanish. She completed her master's at the Jesuit School of Theology of Santa Clara University with a certificate in women's studies and religion. Barb's research interests include the interactions between gender, sexuality, religion, and politics. So I'm going to leave you in the capable hands of Barb's and Ganza, who are going to moderate this panel discussion. So thanks to you all.
Hi, everyone. Our names are already said, and I guess my name can be very hard to pronounce, but I'm going with Ganza. Ganza is much quicker and easier. We will be working with Barbara, and for this very first panel, we'll hear from our 5 panelists, and they will be taking us through the problem of the relief to development gap. And
sorry, I'm going to introduce the panelists.
Thank you. I was like,
thank you very much. Apologies for that.
It's creative.
Okay. Okay, I'm just making sure my photos match the names here. Okay, Anne. Yes, fantastic. Okay, so Anne is Anne, pronounce your surname. Willhoite. Anne Willhoite is the Mental Health and Psychosocial Support Team Lead for the United Nations Children's Fund, or UNICEF. And Anne is the Mental Health and Psychosocial Support Team Lead. She has 20 years of experience working with MHPSS in global development and humanitarian emergencies. She's currently responsible for MHPSS in child protection across humanitarian and development settings in UNICEF. Previously, she served as a senior mental health advisor to USAID, where she coordinated and advised mental health work across the agency and advised the Victims of Torture Fund. Anne spent a large portion of her career as international clinical advisor for mental health with the Centre for Victims of Torture, covering Asia, Africa, the Middle East, Eastern Europe, and South America, and started with Jesuit Refugee Service. Anne has lived and worked in South Africa, Sierra Leone, Kenya, and Malawi, implementing NHPSS programming. Additionally, she has worked as a technical consultant to the World Bank, the World Health Organization, and Harvard University's François-Xavier Bagnot Center for Health and Human Rights, and holds an MA in Counseling Psychology from Northwestern University from Chicago. Anne has spent her career focusing on her passions on MHPSS and human rights, humanitarian response, psychological interventions, supervision, workforce development, and advocacy. So, Anne, you're very welcome.
Thank you.
Okay, so next we have Yinka. Yinka. Okay, we have Yinka. And Yinka is a Sierra Leonean born licensed psychologist. She's board certified in group psychology by the American Board of Professional Psychology, a tenured professor in the Department of Psychology at the City College of New York, City University in New York, and at the Graduate Center. She's cared for forced migrants as well as survivors of torture, armed conflict, and human rights abuses from around the world at the Bellevue Program for Survivors of Torture since 1999. Guided by the urgent need to acknowledge and provide culturally informed services for survivors who have fled their home countries and are struggling with mental health challenges and or with psychosocial disabilities, Yinka's research utilizes qualitative, quantitative, and mixed methods approaches to better understand and address such challenges while working with local partners to improve validity and cultural significance. Over the years, her advocacy, clinical work, research, and teaching have focused on three specific areas. Firstly, the experiences of forced migrants, survivors of human rights abuses and armed conflict. Secondly, mental health interventions in low-resource settings. And thirdly, mental health consequences of service provision. So, Yinka, you're very welcome. And next, we have Josiah.
Yes.
You're very welcome. So Josiah Kaplan has worked for more than a decade in child's rights research and knowledge management with a focus on mixed migration, livelihood, social protection, and conflict issues across the INGO sector, UN system, and academia. He previously served as Senior Research and Innovation Advisor for Save the Children International's Migration and Displacement Initiative, where he led a varied research and innovation project portfolio. Prior to this, Josiah has served a variety of research and practitioner roles, including as a humanitarian evidence advisor for Save the Children UK, as a researcher with the University of Oxford Refugee Studies Centre's Humanitarian Innovation Project, and a wide range of consultancies with INGOs, UN agencies, and think tanks across the aid sector. He's an American citizen and holds a master's and PhD from the University of Oxford, as well as an undergraduate degree from Dartmouth College. You're very welcome.
Can I just announce my current role is as
Yes.
UNICEF Child Protection Specialist at our Global Office of Research and Foresight.
Thank you very much. Fantastic. And now we come on to Anne Nolan. Anne, you're very welcome. So Anne Nolan, Assistant Professor in Social Policy with a research and teaching portfolio in global health. She's a technical specialist in HIV and sexual health with research in sexual and reproductive health and rights, the politics of health, inclusion health, and the regulation of sexuality and other contested policy domains. Anne is a former executive director and chairperson of HIV Ireland Limited and an advocate for the rights of sexual minorities and people living with HIV. She's led the development of global policy frameworks for adolescents and most at-risk young people with UNICEF and UNAIDS, and has been an advisor to Ireland's International Development Cooperation Programme at the Department of Foreign Affairs and Trade, Irish Aid. Anne brings to academia a lengthy professional career that has emphasised the relationship between evidence and policy at national, bilateral and multilateral levels. So you're very welcome, Anne.
Thanks, Rachel.
And finally, we have Gareth Hussain. Gareth is an accomplished professor in medical ethics and law at the School of Medicine here in Trinity College. He holds a medical degree, a master's in bioethics from the University of Toronto, and a PhD in bioethics from the University of Birmingham in the UK. His professional journey encompasses extensive experience in health research, health policy, and field epidemiology, with a particular emphasis on humanitarian settings. Dr. Hussain's primary contributions lie in the field of bioethics, focusing on research ethics, public health ethics, and humanitarian ethics. His commitment to ethical considerations extends beyond the classroom. He's played a pivotal role in ethics-related consultations, collaborating with major international agencies such such as the World Health Organization, UNESCO, and notably he's been a member of the Ethics Review Board of Médecins Sans Frontières since 2020, contributing to the ethical oversight of medical research. He's also a valued member of the Ukraine Clinical Research Support Initiative. Dr. Hussein's multifaceted expertise, extensive teaching experience, and active involvement in shaping ethical frameworks on both national and global scales underscore his commitment to advancing medical ethics, research integrity, and humanitarian principles in the field of healthcare. So you're all very welcome. So we've got a huge range of expertise, practice, experience in so many different countries. So I'm going to hand over to our two moderators now, and thank you very much.
Thank you so much. I hope this time is the right time now. I'm going to ask our panelists to really start us off by really talking to us from their mind, what does this gap look like? The gap that we're discussing today, what does it look like? And I also wanted us to really get to hear from you what are currently the issue that we are struggling with in attempting to close this gap. And perhaps maybe talk to us lastly about what could be the greatest leverage points. Thank you.
So, should we just jump in?
Shall we just go first?
They go in order? Okay.
Sure. Okay. I'll take the risk of going first here. You guys can catch everything I've forgotten. So I think three things probably are our biggest gaps. Now let's say we have lots and lots of gaps. So I'll focus on the three that I think are most pertinent from my perspective. The first, I think, is probably indisputable that it's financing. In order to do any of this, we have to have financing. I used to be a funder. I know that funders don't want everyone to say that it's only about financing, but it is. So I think one of our biggest challenges with financing right now is that it's not multi-sectoral as much as it needs to be. And this goes back to a lot of things that Wietse was referencing in his opening talk. But also from, if we're talking on the very more humanitarian side, it just is very multi-sectoral in terms of it being fairly siloed. That's the international or the global structure through the IASC on how we work with the cluster system for now. We need to figure out how to work better multi-sectorally, but right now we need better financing across those structures. In development, I think the number is something like less than 2% is dedicated of health budgets for mental health and psychosocial support. That's only looking at the health sector. We don't even have data on the social welfare systems or the education sector. So we need to really look at how we can make those multi-sectoral funding structures come together. If we only fund things in health, we will not have the comprehensive approach to mental health and psychosocial support we need across the nexus. The second thing I think is understanding the gap itself. We don't have enough data on what the gap is. We don't have enough data on the financing aspects of it, but also on the need. So I think other colleagues will talk a lot more about that, but I think just understanding the gap is still an issue. We know a lot more about what works, but understanding what the gap I think is important. And then third, which I think is the biggest stagnation once we have the funding, and of course I'm slightly biased, but is the workforce. And so I think this is where we really need to come together, a systematic approach, and I'll talk more later about what interventions we can use, but to have that systems approach to workforce, we need financing systems, we need collaboration between, we need people to fund collaboration between universities with each other in low and middle income countries. We need to understand from other sectors what works for human resource development, and then we need to support the next generation of practitioners to lead from the places where the work is happening to avoid these colonial structures that we know exist and that have not served us well.
So you already know I'm Sierra Leonean, and Sierra Leoneans, we love proverbs for everything.
Yes.
So for me, what I love about this question is it just gets me going. We have a proverb in Sierra Leone that goes, for no side you go, you get for no side you come out. If you want to know where you're going, you have to know where you've come from. When I think about what you're asking about the current gaps, with Sierra Leone, for example, we have to look to the past. We had a war that went from 1991 to 2002. The war was caused by many weakened states, many corrupt political states. Coming out of that war, then we went into other things. The war left us, we were already pretty left with very little, very ravaged, poor systems. The war. Then you had Ebola. You had mudslides. You had COVID-19. All of these things added to the burden that was already there, the problems, the difficulties. So you have those coming into where we are now. And now some of the struggles that we have are some of the ones that you spoke to and Wietse mentioned, the poverty. What are we talking about in terms of hunger, in terms of being able to help young people? What are we talking about in terms of access to skilled service providers, skilled health professionals? Gender-based violence. We're talking about substance use and abuse. Right now, we're struggling with Kush that is just ravaging our young population. So when we think about where we are now and where the gaps are, we have to begin to think about all these multiple facets that come to play on allowing us to move forward. So I'm going to stop for now. And
Thanks. I'm going to risk being a little boring in saying how strongly I agree with my colleagues, but also to take advantage of that fantastic keynote, just to point out that Nexus, that humanitarian and development, those are all boundary objects. And these are all constructs. And I think it's very important when we talk about multidisciplinary, we also remember historians and we remember a critical deconstructionist humanities-informed lens about where these terms came from, because humanitarian implies deviation from a norm established by a global North international architecture. Development implies, and this is one of the few times I get to use this word in an academic audience, a teleology, right? A linear narrative. And the word nexus, to me, is a mea culpa for saying, actually, that's not the way the world really works, and so we're dumping everything in. So how do we address this problem? This problem is a conceptual framing first and foremost. How we can get that into a bullet point on a PowerPoint to leverage the financing we need in international organizations is, I think, where the real devil in the detail is. Now, in terms of leverage points, to end on a positive note, I think we're headed in the right direction. As a community of practice, we know that integrated multi-sectoral, multi-thematic, and transdisciplinary approaches to MHPSS, programming, system strengthening, advocacy, and policy are all the right directions. We know, unfortunately, while we can't have a monster intervention, we do need to think about social determinants, investing in conflict prevention, investments in education, healthcare, investments in economic opportunities and sustainable livelihoods. But we're headed in that direction. What I think we really need is mechanisms or investments in existing mechanisms to maintain the continuity and partnership development that we have in this room here to actually get this into practice.
Okay, thank you. And again, I couldn't possibly disagree with anything that my fellow panelists have said. I suppose one of the questions that I would love to ask of all of you here, can I see a show of hands of people who are representing institutions from the Global South, where many of our humanitarian interventions take place? 1, 2. Okay. That for me is having, worked in international development, and we were having these same conversations. I know nothing about mental health and psychosocial support, but in terms of the first big budgets around HIV, where the world began to come together through the United Nations commitments and UNGAS and bilateral organizations getting behind that commitment, was starting to talk about the development to sustainability gap. Thank you. And of course, this is ongoing, and I don't think we've got that right at all. Particularly, I find it quite stark in academic circles where we are still having the narrative about global health and international development between ourselves in high-income countries. So the key audience that we need to be having this dialogue with around interdisciplinarity, around sustainability, around the effectiveness of our approaches is that communal dialogue, is that the most important half of us is missing. In terms of global health. So I think that's fundamental. The second barrier, and always has been, and again, over 30 years, it's really hard to see how this has changed in my experience within political systems is that the political cycle itself is very much at odds with the goals and objectives of sustainability. And we have not found a way forward out of that. There is global recognition from all the actors that you identified. Wilke, couldn't disagree with you on any of these issues. But that is a huge barrier to sustainability, is changing that democratic cycle.
Okay, as if it's not hard enough to be in the first panel, now I'm the last speaker in the first panel. So perhaps a piece of information that I didn't mention, I should have mentioned that. I'm from Sudan. My professional experience started in Darfur, the armed conflict. Well, it started in 2003, and unfortunately it's been going till now, and now it's a kind of like full-fledged civil war in the country, unfortunately. How does that relate to what I'm going to say here is, I believe that one of the main gaps, or when the barriers or the challenges, if you wish, is the mindset that is running the humanitarian system in the whole world. In terms of who is running the show is basically the funding agencies. And whether we like it or not, what's happening, it's most of the planning and the thinking is happening in kind of like closed rooms in high-income countries, mostly, no offense, by white men in the room. So this is at least the impression that we have. Going to the field and talking to the people and living with the people, and this was part, by the way, of my doctoral thesis as well, is if we talk about like the theoretical part, then I believe that the starting point should be the mindset, and really love your presentation and your work. It's because it's talking to the people, with the people, about the people. So I believe that one of the main gaps is a conceptual gap. By this I mean that we need to come to the co-creation, as you describe it, of what, to set the goals, there should be the mindset from which we are setting these goals to begin with. And perhaps we can elaborate more as we go on in the discussion. Yeah.
Great, thank you so much to our panelists for this response. Our next question is directed toward Ms. Willhoite, Ms. Akinsuler-Smith, and Mr. Hussein. The infrastructure and available systems to leverage external support for MHPSS programs can vary considerably across settings affected by conflict. However, when we consider the most fragile states that lack this infrastructure, what are some of the initial steps humanitarian, academic, and development actors can take together to support system strengthening and external buy-in to building MHPSS systems? So whoever would like to begin, please take it away.
So
do you want to go first this time?
Sure.
Yeah.
Sure, I'll give you a break.
Thank you.
I guess when I think about this question, it goes to something that we've already begun to talk about, the co-creation, the partnerships, building sustainable partnerships. Building sustainable partnerships with not only local communities, but also in terms of the government and how we go about creating that. So, example, in Sierra Leone, we have had in our laws since 1902 the Lunacy Act. The Lunacy Act basically criminalizes people who have mental illness, right? And after the conflict, because we became aware of mental health challenges, there was a real push in local communities to shift this. Well, a mental health policy was put together on paper. That was put together 2010 to 2015. It sat there. It sat there. It didn't move. And now, most recently, I believe this past year, we now have, I think it's called the Mental Health Bill, that again is sitting there, the Mental Health Review Bill. We also need the wherewithal from our governments to help not only acknowledge, but make things happen. And that goes back to resources and funding. I'm going to pause there.
Okay. Do you want to go?
Oh, yeah, please.
Okay. So
I agree completely with everything that you have mentioned, Yinka. And I think to put some tools around it that we have been working on at UNICEF, the minimum service package, thankfully after much work across sectors with community-based organizations, with NGOs, with academics, with UN agencies, we have developed the MHPSS minimum service package, which was launched last year. It's a ISC package, but done in collaboration with UNHCR and WHO, UNFPA, to direct us exactly in how to collaborate in these. What are the question specifically is, what are the first steps we can take? These are the first steps we can take. It's outlined for us in actions. It doesn't need to be only these steps. It's a minimum service package, but these steps can help us know exactly what we should be doing for quality implementation, especially in emergencies. Now, it should also then extend across the Nexus, why we're here for this conversation. It speaks to advocacy. It speaks to working to build connections across sectors. And so all of the steps are there that please go to MHPSSMSP.org. You can also engage in this tool. And so that I think is a really helpful, very beginning step. It's not the end step. There's much more that needs to be done, but it can help direct us. Then I think that there are other system strengthening things that we need to really be doing together on workforce especially, which I mentioned in my opening comments, but maybe just to speak a little bit more to that. There are two things that we're working on at UNICEF that I think can go a long way in supporting the system strengthening for the workforce. The first is EQUIP. You can also go to equipcompetency.org and register yourself to work on this tool. It's really an assessment tool to help assess competencies of frontline workers in mental health and psychosocial support. And it works across sectors. You could be a psychosocial worker, a community worker, you could be a psychiatrist. There's different competencies laid out for foundational helping skills, and then also for a lot of different interventions. Self-Help Plus is one of them, which Wietse mentioned before, and lots of other kind of global packages are in there with the associated competencies. So I think that can really help build the systems in that we're all talking about the same types of competencies that are needed to provide the interventions that we're hoping of across the layers of the pyramid. We're also working on something that we don't really have a name for yet. We're calling it the Global Course, so we'll stick with that. But it's a global course for mental health and psychosocial support frontline workers that really provides just basic level understanding of how to implement services, because there is nothing yet that is a unified kind of understanding of what to do across sectors. So we have that too. I'm over time. I could talk to you a lot more about it, so find me later.
Okay, and again, I think one of the things that sometimes we forget that, especially in armed conflict settings, and this I've disclosed my own biases while choosing this example in particular. First of all, I'm from a region where conflicts stay for a decade or more. They have the Syrian model, the modern Yemen, and now, unfortunately, the Darfuri model. So what's happening here, there were pre-existing vulnerability within the communities, within the structures. So this is one of the things that I believe that we need to consider as well when we are planning for. There's no one-size-fits-all, basically. So what we need to do is to talk to the communities, to walk to the communities, especially when we're talking about the sustainability of our interventions. The general, again, back to the mindset, it's not a matter of helping people just to, well, find them something to eat, a shelter, some protection, some health services, and that's it. When the fund is over, we leave and go and leave the communities more or less at a very similar stage where they were before coming. So I believe that it brings us back to the mindset, what are our goals? If we want to empower the people to leave the services by themselves, we have to include this in our interventions. So I believe that to help them, we need to help the people based on their capacities, and this is one of the great examples that were presented to us, is about how the people themselves were involved in this. So even if you leave tomorrow, not tomorrow, basically, hopefully not. But anyway, if you leave this community, these communities have at least the seeds that you have planted that they can grow and this level of self-dependence on them. So back to the issue here. I believe that we have to yes, sit together, come to kind of hopefully what are not only the principles but the theory. And this is, as an academician, perhaps we have to make some separation here, but again, I'm aware of the time. So it's not enough just to set the humanitarian principles that guide us. No, we need to have perhaps a bigger umbrella about the theory that is guiding us. I'm not advocating for any specific theory, basically, but again, to come to this level of agreement is important. And then we have to have our clear goals about what about the people affected by our interventions, whatever the intervention is, and to bring them abroad where they are now and how we can basically take them with us to the point when we leave, and we will, as humanitarian players, then they will be able to sustain the intervention that we have started. Thank you. Yeah.
We have our very last question to our panelists. Okay. And we wanted to direct this to Anne and Josiah. And we want to ask that, given that funding is often more frequently secured for projects in countries that have better infrastructure and governmental buy-in to sustain MHPSS and system strengthening program. So we wanted to ask you, what role do you all of us in this room have, if any, of course, in promoting international funding for system strengthening in contexts where the infrastructure is severely lacking?
Please go ahead.
Sure. Okay. Thanks so much. Again, I don't come from any background in mental health and psychosocial support. What I would say, is just to repeat what I kind of said at the beginning, is that we've been grappling with this issue of sustainability for a very long time. And so the key question is, how do you change the thinking in political systems around low-hanging fruit, short-term gains, So we see it in our institutions all the time. We're giving very small amounts of money for a mental health and psychosocial support project that might run over 3 or 4 years, and then you run out of funding. It's the same. I mean, I'm working on a project in Ethiopia, exactly the same. Once the life of that intervention is gone, there is no system readiness, there's no funding to continue that. We all witness, I'm also recruited by a number of our Irish embassies, for example, to teach staff, instead of building an infrastructure for health equity and investing heavily in the country, that would allow for a strengthening of a focus on health systems, strengthening on equity overall. So these are much more expensive, but we see it in our own countries as well. It's not just in international development or humanitarian responses. I mean, you'd very easily get funding for a creative arts therapy in a poor community in the North Inner City because it's currently the intervention du jour. But if you ask for long-term investment in growing the structures and the infrastructure and improving educational access in a particularly poor community, that's never been secured since the foundation of the state in the last 100 years. So these are issues that I think we're grappling at all levels. Sorry.
Thanks. So I would start by saying whatever the solution is, it's going to require advocacy, which means we need to work through our advocacy mechanisms. UNICEF, for instance, co-leads the IASC's reference groups advocacy working group on MHPSS. One of the challenges we face in the advocacy space is we need a better understanding of the funding landscape itself. And we struggle because it's not easy to capture where spending is already being spent, given how multi-sectoral, multi-dimensional the phenomena of MHPSS is. Down to the fact we have different program codes and framings for what we collectively refer to, another boundary object, as MHPSS. So we need more, as a sector, market research. Second, I think we need to be very savvy and ruthless about leveraging policy windows. The policy priorities du jour are climate change, are migration, displacement, politically charged issues, lots of funding, a lot of perhaps frustration for those of us who have worked in this sector to see issues being rebranded under new terms. But that's the opportunity we face. So how do we take advantage of, loss and damage financing coming out of COP27, the Green Climate Fund, the Adaptation Fund? How do we leverage some of those resources that are available by bringing it to the MHPSS lens? And of course, third, we need evidence. We need evidence to make the business case. We need evidence on what we call innovation, how we're even defining innovation, what we mean by scale. This is obviously a role for real implementation sciences. And it's a role as well for knowledge management, ensuring we're not duplicating effort. UNICEF has done work on the MMAP measurement tool for mental health of adolescents. We've worked on an evaluation framework. There's many, many more examples that I can give. But a critical point here is not just about research knowledge generation or even knowledge management. It's about the communication, the advocacy packaging. We can spend the next week talking about the complexity of and structural inequalities in the global system, but at the end of the day, how do we translate that into a sellable message that will leverage resourcing? I think we really need to think about that from almost a sharp comms perspective. Thank you.
Great, thank you so much to our panelists for these thoughtful responses. And now we have just under 10 minutes for questions and comments from you all in our audience. Please raise your hand if you have something for our panel. Yes, coming to you.
I can't believe we all get to 2 minutes. These are big issues to try to fix.
Thank you. My question is, my name is Kozee. I'm a PhD student at Trinity College. My question is, so do you think that this system is kind of working that we have, and we just need to add more to it, fix the things that are not working, or do we just completely throw it out of the window and do something new?
The $1 million question, right? Maybe just really quickly, I don't think it's either. I think it's probably a blend of both. I think, as Yinka's proverb said at the beginning, we still have to understand the past and what did work and what is working, but not be stuck and wed to it. I think it's also probably pretty impossible to throw everything out and start totally over. I think there are good things in there, but sometimes there's a burn it all to the ground philosophy that you have to push through in order to get even a little bit of change.
Yeah.
Beautifully said.
Yeah, I mean, I agree. I think global health, from my perspective, I think in terms of overseas development assistance, bilateral and multilateral engagement, and then also academia's role in that has also, in a way, has become the problem it has set out to solve. But as Anne says, there are lots of examples of really effective interventions that have made a huge difference. It's how then also we bring the political system on board with that, how we fund that better, how we ensure sustainability of something that has shown us very clear objectives. And as Jonah was saying, capturing those lessons and not giving up on breaking down of continuing advocacy, and academics are in a very good place to do that because we're respected by the political system as an expert voice, whether we are or not. They perceive us as such, and so therefore I think we have a very important role to play in advocating for a different way in terms of funding and engaging with evidence around what is effective and how you realize change.
Great. Other questions for the panel? Yes, one in the back.
Thank you so much, and wonderful comments. So first, I'm William. I'm from Boston College, but I also want to mention that I'm Ugandan. And oftentimes, one of the panelists asked the question, how many people are from the Global South? So when people invite me to conference, I always say no, not because I don't want to travel, but because it's so complicated when you're from the Global South to travel to any of these countries. That's not my question today. I wanted to just follow up on one of the conversations about the political nature and hear your thoughts about how you engage politicians. One of the issues I've encountered is that we have these cycles, political cycles, and so people come in and people get out, and then you have ministers in 5 years, 4 years, and they're out. How have you, from your experiences, been able to capitalize on these changes? Either capitalize, but how have you been able to work with these systems to be able to continue the work even when some people leave? Yeah.
I can take that. In terms of when we say political engagement, it's critically important to think about multiple levels in a political system, from national ministries, but down to state, local, and also where political systems become what we might call perhaps reductionistly informal, right? Because they're not necessarily part of the state apparatus, but they provide the social kind of infrastructure within a community. It's not a very sophisticated answer, but relationship building, ensuring you and your organization have a continuity in your focal point, so that even if the counterparts come and go, there'll be someone there to have that memory. I want to give a concrete example when we talk about integrated approaches. I'm a child protection specialist for many years, and still to this, still today in UNICEF. Some issues of mental health are a child protection issue. It's only when we started working with social protection colleagues to engage with, say, local ministers working on public financing, we were actually able to embed sustainable child protection approaches at a level, because we understood, working with our social protection counterparts who understood how budgets are made. And so I just want to sum up by saying it is complicated. There's not obviously one size fits all solution, but continuity in relationship, investment in relationship, having investment in relationship at multiple levels of a government, and finding a government champion or champions that you really are looking to help you navigate that system.
And I'm going to piggyback off of what you just said, Josiah, because I think, again, of the Sierra Leone example, where we have changes, but also thinking about partnering with local community-based organizations, with faith-based organizations, because with the youth readiness intervention that we have worked on in Sierra Leone, I mean, one of our most consistent partnerships has been with Caritas through the years, and that has remained stable.
Great, we have time for probably one more quick question and response. There was a hand.
Faith-based is never discussed in this forum, but it's
yes.
essential.
Thank you all, and thank you to you, brilliant speakers on expertise. Thank you. I guess I'm sitting with a reflection which is maybe relevant to lots of us in the room, which is the way in which the system that we're all operating in, which is quite a capitalistic system, means that subject to the funding and financing models, everybody gets quite focused on their kind of siloed, evidence-basing a particular intervention that inevitably becomes kind of competitive because of the scarcity or perception of scarcity of resources. And we don't do what you spoke about in the earlier talk, which is think about like how are we understanding how the kind of intersectional interventions, which often aren't simple and they aren't easy to just isolate a kind of 6-stage model or, a something plus, which lots of the kind of interventions that are promoted are, which are kind of things that you can mobilize in with kind of non-clinical or non-therapeutic workforces. So I guess it's just a reflection on how, over the next few days, do we really think about what are the ways that we're going to counteract the system that we're operating in order to be able to work together? And some of that's the funders really investing in collaborative interventions, which mean doing a lot of the resource building of how we work together. And if you're going to work in through localized responses and really support communities to respond to their community needs or kind of incoming community needs or displaced communities, what are the resources needed that enable lots of different interventions to work together effectively so they don't become a monster intervention, so that the people using those different services don't have to tell their story over and over again to get different support. And I think all of us in our different ways can advocate for that within the worlds that we work in. And I hope that that's something that comes out of the next few days together. So I'm Gabriella from AMNA.
Thank you so much. I want to really do what Africans are good at doing. They tell us, when you have an opportunity, use it. I have an opportunity for 1 minute to use, commenting back to one thing that our speaker has mentioned. I don't want to mention your name. I want to say, in the global north, some good point you mentioned, there's a lack of representation of people from the Global South in such settings. And I wanted to add on that burden to say there is a serious issue of visa inequity from the Global South people. And I'm trying to think here, why do I live here without talking to the group? Park in your parking lot and say, what if next time we switch these meetings, Global North access Global South easily? We don't access Global North easily. And for us, that is a traumatic experience. It's a mental health aspect on its own. So we're talking mental health, and you're still talking people affected with mental health issue due to visa inequity. And I want to dump that in, and I invite you to really clap hands for our panelists today. Thank you.
Thank you so much to our panelists, to our moderators, and we're going to move now into the breakout discussions. And how this is going to work is we've got two new facilitators, and I'm going to introduce them briefly, and then we've probably got room here for two groups to have their breakout discussions in this space. And then my lovely colleague, Sarah, who's just running at the back there, is going to direct you to another space just so that you can actually hear yourselves think. So we're going to do that for 25 minutes. We're going to give you 25 minutes in your group, and then we're going to come back here for a 15-minute discussion of what's happened in the groups. And then we're going to let you have some lunch. Okay, well deserved at this point. So I'm going to introduce Kozee and Thomas. Are they here? Brilliant. So do you want to come up? Do you want to go back to your seats? Thank you so much, everybody. So I'm just going to introduce you here, and then people are going to split into groups, and you're going to be kind of roving around, listening to conversations and helping people. So I just want to introduce you to Kozee Enalama. Thank you. Kozee is an assistant professor at the Department of Social Work at the College of Health and Human Services, University of New Hampshire. Her intervention research focuses on mental health disparities among children and youth of sub-Saharan African origin, immigrant and refugee, and Black US